Usually when we talk about making a medical diagnosis, there's this expectation of precision.
Oh, absolutely. We want it to be exact.
Right. We expect it to feel almost like engineering.
Hmm.
I mean, you fall off a bike, you break your arm, the x-ray goes up on the screen, and the jagged white line is just sitting right there. The doctor literally points to it and says, there's the problem.
It's entirely binary. It's either broken or it's not broken.
Exactly. It's incredibly clean. And I think as patients or even as clinicians, we find a lot of comfort in that. We like our diseases to be visible. We want them perfectly categorized, and we want them to declare themselves loudly.
But the reality of chronic disease is it's rarely that accommodating.
No, it really isn't. And the moment you step into the world of preventive cardiology, specifically when we start talking about dyslipidemia and cholesterol, that comforting binary x-ray machine suddenly feels completely useless.
Yeah, you're flying blind if you're looking for a simple fracture.
Right. Because we are no longer looking at a single acute event. We are trying to measure this slow burning invisible fire that is just smoldering inside the arterial walls over the course of decades. I mean, it is the absolute definition of diagnostic muddy waters.
The slow-burning fire is actually a perfect way to conceptualize it, because for a very long time, the tools we relied on to measure that fire, while, they were groundbreaking back in the 70s and 80s, they were essentially blunt instruments.
Very blunt.
Right. We were using these incredibly crude static approximations to try and somehow quantify microscopic cumulative biological damage.
And we've basically been doing the math wrong for decades.
Yeah.
Which brings us to our mission for you today. Welcome to the Deep Dive. Today we are looking at a document that completely rewrites how we fight that invisible fire.
It really does change everything.
So if you are a medical student prepping for the USMLE Step 2 CK, or if you are a practicing clinician looking to instantly update your approach without drowning in a sea of dense supplementary PDFs, this right here is your ultimate shortcut.
Because those PDFs are dense.
Oh, they are brutal.
Yeah.
But today we are taking a masterclass on the brand new, highly anticipated 2026 ACHA Guideline on the management of dyslipidemia,
which was just published in the journal Circulation. And with its publication, it officially retires the previous 2018 guidelines. And I really cannot overstate how significant this document is.
It's big.
It's huge.
Yeah.
This is not just some minor iterative update where a committee sat in a room and tweaked a few target numbers. It is a fundamental rewiring of our entire approach.
Yeah, it changes how we assess a patient's risk, how we diagnose the specific nature of their lipid disorder, and just how aggressively we intervene.
Absolutely.
So we are going to skip the information overload. We're skipping the endless tables of evidence grading, and we are going straight for the high-yield clinical algorithms and the major paradigm shifts that will, dictate the standard of care for the next decade.
Which is exactly what people need to know.
Right. And to set the stage, before we get into the weeds, the big picture here is that the 2026 guidelines represent a massive philosophical pivot in cardiology. We are moving away from the era of purely statin monotherapy.
That idea that one pill solves the whole problem.
Exactly. And we're moving towards sophisticated combination therapies that target very specific biological pathways in the liver and the gut. But even more critically than the drugs, there is this huge, aggressive push toward early intervention. The new vocabulary you really need to know is lifetime exposure to atherogenic lipoproteins.
And to put that philosophical pivot into historical context, the old way of thinking in preventive cardiology was highly reactionary.
We basically just waited around.
Right. We waited. We watched a patient's risk slowly climb throughout their 30s and 40s, and we essentially waited until their calculated risk score reached an arbitrary threshold in their 50s or 60s. And then, and only then, did we hit them with a statin.
Like putting out the fire after the house is already half burned down.
Exactly. The new 2026 guidelines scream from the rooftops that this approach is flawed because atherosclerosis is driven by the absolute duration of exposure. It is a cumulative disease.
Okay, let's unpack this. Because before we can even talk about intervening early or prescribing combination therapies, we have to know how to diagnose the problem accurately.
Right. You need the right numbers first.
Yeah. And that takes us to our first major paradigm shift, which is all about the math. The guidelines have completely overhauled the equations we use to calculate a patient's lipid levels and their overall cardiovascular risk. And the very first casualty of this update is a mathematical formula that almost every doctor listening probably memorized in medical school. The Friedwald equation is officially dead.
May it rest in peace.
Seriously.
I mean, it served us well for a half century. For decades, the Friedewald formula was the absolute standard way that laboratories all over the world estimated low-density lipoprotein, or LDL cholesterol.
And the math was simple, right?
Very simple. You take the total cholesterol, subtract the high-density lipoprotein, the HDL, and then you subtract the triglycerides divided by 5.
I remember learning that and thinking it was so elegant, like we couldn't easily or cheaply measure the LDL directly in a standard lab machine, so we just guessed it based on the other numbers.
Yeah.
It was a process of elimination. Total minus the good stuff minus the triglycerides divided by 5 leaves you with the bad stuff.
Elegance and simplicity. But the new guidelines give a firm Class 1 recommendation to abandon it completely. They explicitly state we must use either the Martin-Hopkins equation or the Sampson-NIH equation instead.
So walk us through the biology and the math here. Why is the Friedewald equation being thrown out? Like, what was actually wrong with dividing the triglycerides by 5?
The fatal flaw of the Friedewald equation lies entirely in that divided by 5 constant. Back in the early 1970s, Dr. Friedewald observed that in a normal fasting state, the mass of triglycerides inside a very low-density lipoprotein particle, a VLDL particle, is roughly 5 times the mass of the cholesterol in that same particle. So by dividing the total triglycerides by 5, you could estimate the VLDL cholesterol.
Ah, I see. So it assumes that the ratio of triglycerides to cholesterol inside these particles is perfectly static across every single human being on Earth.
And that is precisely the problem. Human biology is wildly dynamic. It is not a fixed constant. Think of the Friedewald equation like a suit that was manufactured using a single fixed template.
Right.
If you happen to have the exact average measurements of the mannequin it was designed on, the suit fits beautifully. But if you have extreme measurements in any direction, the suit just rips at the seams. That fixed 5-to-1 ratio completely falls apart at the metabolic extremes.
So what do those extremes look like in a real patient? Like, give me a clinical scenario.
Let's say you have a patient with metabolic syndrome and their triglycerides are surging. Say they're at 400, 500, or maybe 600 milligrams per deciliter. In that state, the VLDL particles become massively engorged with triglycerides.
The stuff full of fat.
Exactly. The ratio is no longer 5-to-1, it might be 10-to-1, or even higher. If you force the math and divide those massive triglycerides by 5 anyway, you end up wildly overestimating the VLDL cholesterol.
And because it's an equation of elimination, if you overestimate the VLDL, you mathematically underestimate the LDL.
Exactly. You end up with a lab report that tells the doctor the LDL is a perfectly safe 70, when in biological reality, the true LDL is maybe 110 and the patient is in danger.
Wow. That's a huge blind spot.
It is. And the same dangerous underestimation happens at the other extreme, too. When we use our modern, highly potent drugs to drive LDL down to ultra-low levels, say below 55, the fixed ratio again warps the math. We simply cannot afford to use an equation that gives us a falsely reassuring, artificially low number when we are managing high-risk patients.
So the Martin-Hopkins equation steps in to fix this. How does it work without getting, too bogged down in the calculus?
The Martin-Hopkins method throws away the fixed constant. Instead of always dividing by 5, it uses an adjustable factor. It analyzes the patient's specific triglyceride levels and their non-HDL cholesterol, and it selects a dynamic denominator from a massive validated data table.
Oh, interesting.
Yeah, that denominator can range anywhere from roughly 3 to 11. It essentially tailors the math to the exact metabolic state of the patient sitting in front of you.
That is a phenomenal upgrade. So for anyone listening who is making clinical decisions or facing a tough diagnostic scenario on the boards, if the lab report hands you an LDL calculated by Friedewald and the patient has triglycerides of 450 or an LDL hovering around 40, you have to know that number is a mirage. You need the Martin-Hopkins or the Sampson equation to see the true clinical picture.
Absolutely. Do not trust the Friedewald in those extremes.
Now, speaking of patients with high triglycerides, this brings up another massive point of clarification in the 2026 guidelines. It's the age-old debate that every phlebotomist and primary care doctor deals with literally every day: fasting versus non-fasting lipid panels.
Oh, this is one of the most practical daily workflow updates in the document. For a routine baseline assessment in a primary care clinic, a standard non-fasting lipid profile is perfectly acceptable.
Good, because patients hate fasting.
They despise it.
Hmm.
And the data shows that for the average person, a recent meal doesn't drastically alter the clinical decision-making for LDL. And honestly, it is vastly more convenient for the patient, which heavily increases compliance. If they don't have to starve themselves all morning, they are far more likely to actually show up to the lab and get the blood drawn.
I love when guidelines acknowledge human behavior. But as with all things in medicine, there are major caveats where a non-fasting panel will lead you astray, right?
Definitely. There are 3 specific scenarios where a fasting profile becomes absolutely mandatory. The first is if that initial non-fasting triglyceride level comes back at 400 milligrams per deciliter or higher.
Because at that point, you need to know if the high triglycerides are just from like the massive breakfast burrito they ate an hour ago, or if their internal metabolic machinery is actually broken.
Exactly. You have to wait for the gut to clear out the chylomicrons, the fat-carrying particles from the diet, to see what the liver's baseline triglyceride factory is actually producing on its own.
That makes perfect physiological sense. What are the other 2 scenarios?
The second scenario demanding a fasting panel is if the patient has a strong family history of premature ASCVD.
Meaning atherosclerotic cardiovascular disease at a young age in their parents or siblings.
Right. And the third scenario is if you suspect a genetic triglyceride metabolism disorder, like familial hypertriglyceridemia. In those high-stakes cases, you really need the absolute baseline, unclouded by recent digestion.
All right, so we have modernized our LDL math with Martin Hopkins, and we know exactly when to make the patient fast. But that is just measuring the lipids themselves. The next massive mathematical upgrade is how we calculate what those lipids are actually doing to the patient's future, out with the PCE and with PREVENT and the CPR model.
This is a monumental shift for population health. For years, we used the pooled cohort equations, the PCE, to estimate a patient's 10-year risk of having a heart attack or a stroke.
The classic ASCVD risk estimator app on everyone's phone.
The very one. Well, the 2026 guidelines officially retire the PCE for adults aged 30 to 79. The new, undisputed gold standard is the American Heart Association PREVENT equations.
We are abandoning the PCE entirely, so why the switch? Like, what was the PCE missing that the PREVENT equations capture?
The transition to PREVENT represents a profound evolution in how we define cardiovascular risk holistically. The PCE was heavily focused on the traditional big hitters, age, cholesterol, blood pressure, smoking, and diabetes.
Right.
But it had major limitations. The PREVENT equations are a massive leap forward because they are built around the concept of cardiovascular kidney metabolic health, or CKM syndrome.
CKM syndrome. Let's dig into that because the kidney part of that trio might surprise some people who think of cholesterol as purely a heart issue. Why is the kidney suddenly taking center stage in a dyslipidemia guideline?
Because the cardiovascular system does not exist in a vacuum. The PREVENT equations incorporate estimated glomerular filtration rate, eGFR, and albuminuria, which is the spillage of protein into the urine.
Right, but what is the actual biological link there? How does a leaky filter in the kidney translate to a plaque rupturing in the coronary artery?
It all comes down to the endothelium, the delicate inner lining of all our blood vessels. If the microvessels in the kidneys are damaged to the point where they are leaking albumin, or if the filtration rate is dropping, it means the patient's systemic endothelium is under severe oxidative stress and inflammation.
So it's a systemic problem, not just localized to the kidney.
Exactly. Uremic toxins may be accumulating, blood pressure regulation is faltering, and the vascular walls are becoming stiff and calcified. The kidney damage is essentially the loudest alarm bell telling us that the arterial environment everywhere in the body, including the coronary arteries, is deeply hostile and primed for accelerated atherosclerosis.
So the kidney is acting as the ultimate biological sensor for systemic vascular distress. That makes perfect sense. PREVENT takes that into account, whereas the old PCE just completely ignored it.
Furthermore, the PREVENT equations remove race as a biological proxy variable. This is a vital step forward for health equity and scientific accuracy, recognizing that race is a social construct, not a distinct biological risk factor.
Right, that's a huge and important update.
It is. PREVENT also allows us to estimate 30-year risk, not just 10-year risk, which is crucial for those early interventions we discussed. And to operationalize this new equation, the guidelines recommend the CPR framework.
CPR. And we're not talking about cardiopulmonary resuscitation, though, that is a very convenient mnemonic for cardiologists. What does it actually stand for in this context?
The C stands for calculate. You calculate the 10-year or 30-year ASCVD risk using the new PREVENT equations as your baseline foundation.
Okay, step 1, do the math.
Right. Then P stands for personalize. This means you look up from the calculator, look at the human being in front of you, and adjust that baseline risk by factoring in clinical elements that aren't in the math. Things like a severe family history, chronic inflammatory diseases like rheumatoid arthritis, or specific biomarkers.
Which we'll get into in a second.
We will. And finally, R stands for reclassify or reassess.
Reclassify.
Yeah.
Meaning, if you've done the math and you've personalized the context, and you are still staring at the patient thinking, I honestly don't know if the benefits of a daily statin outweigh the burdens for this specific person, you move to step R.
Yes. Step R almost always involves ordering a coronary artery calcium score, a CAC scan, to physically look for the disease and break the tie. We will explore the deep nuances of the CAC score later, but it is the ultimate tool for reclassification.
Now, before we move on from the diagnostic phase, we really have to talk about the P in that CPR model, personalizing the risk with new biomarkers. Because the 2026 guidelines pulled two specific alphabet soup molecules out of the shadows and placed them directly under the spotlight, LPA and ApoB.
Yes, these are critical.
Let's start with LPA. The document states that measuring LPA is now recommended at least once in all adults for ASCVD risk assessment.
This is a directive that every single clinician needs to internalize. Lipoprotein, pronounced Lp(a), is arguably the most dangerous lipid particle that most patients have never heard of. It is an LDL particle that has an extra, highly specialized protein called apolipoprotein covalently attached to it.
And what makes that extra protein so sinister?
It gives the particle a dual mechanism of destruction. Not only is the LDL core highly atherogenic, meaning it drives cholesterol into the artery wall to build plaque, but the attached APhA protein is structurally very similar to plasminogen.
Plasminogen. That's involved in breaking down blood clots, right?
Exactly. And because of that structural mimicry, LPA actively interferes with the body's ability to break down those clots. So LPA is simultaneously building the plaque and promoting the formation of clots if that plaque ever ruptures. It is highly pro-atherogenic and highly pro-thrombotic.
A truly lethal combination.
Yeah.
But the most fascinating and honestly perhaps frustrating thing about LPA is how it behaves. The guidelines say to measure it at least once. Why just once? Why aren't we checking it every year like a normal lipid panel?
Because a patient's LPA level is roughly 90% genetically determined. It is hardwired into their DNA.
So diet doesn't change it.
Not at all. Eating a perfectly clean Mediterranean diet, running marathons, or losing 50 pounds will do practically nothing to lower their LPA levels. It remains relatively stable throughout their entire adult life.
So it's not a fluctuating marker of lifestyle. It is a permanent genetic barcode of their baseline risk.
Exactly. If you draw the lab and the LPA comes back elevated, specifically if it is greater than or equal to 125 nanomoles per liter or 50 milligrams per deciliter, depending on the lab's units, that patient carries a lifelong, independent, heavily elevated risk of having a cardiovascular event.
And since we don't currently have widely approved standard drugs that specifically lower LPA, though I know RNA therapies are in clinical trials right now, which is exciting.
Yeah.
What do you actually do with that information today? Like if you can't lower it, why measure it?
You measure it because it serves as a massive glaring red flag. If you know a patient has a genetic tendency to build highly thrombotic plaques, it fundamentally changes how aggressively you treat everything else you can control.
Oh, I see.
You drive their LDL down to the floor. You optimize their blood pressure with zero tolerance for elevations. You aggressively manage their blood sugar. The presence of high LPA shifts a patient from intermediate risk to high risk instantly.
That is incredibly clarifying.
Yeah.
Now, let's look at the other biomarker stepping onto the main stage, ApoB, or apolipoprotein B. The guidelines state that measuring ApoB is reasonable to guide therapeutic intensification in adults who are already on lipid-lowering therapy, who have achieved their LDL goals, but who still have CKM syndrome, diabetes, or high triglycerides.
To truly grasp why ApoB is so vital in those specific patients, we have to contrast it with what we usually measure, which is LDL-C.
Right. LDL-C is the standard number on every lab report.
Yes. The C in LDL-C stands for cholesterol. When the lab reports an LDL-C of 100, they are reporting the concentration or the physical weight of the cholesterol molecules that happen to be riding inside the low-density lipoprotein particles. They are weighing the cargo.
Okay, weighing the cargo. So where does ApoB fit in?
Apolipoprotein B is the primary structural protein of all the dangerous plaque-building lipoproteins. Every single atherogenic particle, whether it's a giant VLDL, an intermediate density lipoprotein, or a tiny LDL, has exactly one and only one molecule of ApoB wrapped around its exterior, acting like a structural belt.
So if I can measure the total number of ApoB proteins in a blood sample, I am perfectly counting the exact number of atherogenic particles, regardless of how much cholesterol happens to be inside them.
That is exactly the mechanism.
I like to use an analogy for this. Measuring LDL-C is like weighing the total mass of the passengers riding on a train. But measuring APhA-B is counting the actual physical number of train cars on the tracks.
That is a brilliant way to visualize it. Now, apply that analogy to the patient populations the guidelines specify, those with diabetes, metabolic syndrome, or high triglycerides.
The high-risk groups.
Right. The chronic insulin resistance and altered hepatic metabolism in these patients fundamentally change the way their liver builds these particles. They tend to develop a phenotype characterized by small, dense LDL.
Let's follow the analogy. Small, dense LDL means the liver is producing smaller train cars and packing less cholesterol cargo into each individual car.
Exactly. And the clinical reality is incredibly deceptive here. Because the train cars are so small and carry so little weight individually, the patient's total LDL weight, their LDL-C, might look perfectly normal on the lab report.
It's hiding.
Yes. You might see an LDL-C of 70 and think, well, great, my diabetic patient is at goal, the statin is working perfectly. But because each particle holds so little cholesterol, the liver has to pump out a massive, overwhelming number of these tiny particles to move the same amount of fat.
And it is the physical particles crashing into the artery wall that cause the damage, not just the passive weight of the cholesterol inside them.
Precisely. Those tiny, dense particles are actually more dangerous. They penetrate the endothelial lining of the artery much more easily than large, buoyant particles, and they oxidize rapidly once inside, triggering the inflammatory cascade that builds the plaque. This is the phenomenon of discordance. The LDL-C weight looks safe, but the ApoB particle count is dangerously high.
That is such a critical trap for clinicians to avoid. I mean, if you have a diabetic patient on a statin and their LDL is 65, but they just suffered a TIA or a mild myocardial infarction, their standard lipid panel looks like a paradox. But if you check the ApoB, you might find the particle count is just through the roof. It exposes the hidden danger and gives you the objective data you need to intensify their therapy.
It moves us from treating the surrogate number to treating the actual biological drivers of the disease.
So we have overhauled our diagnostic math. We are using Martin Hopkins, we are calculating CKM risk with PREVENT, and we are hunting down hidden risk with LPA and ApoB. Now, how do we start putting out the fire? Before we jump to the complex prescription algorithms, the 2026 guidelines firmly establish a universal foundation. This is the absolute starting point for every single patient. We are talking about lifestyle, primordial prevention, and the contentious world of dietary supplements.
And the most striking feature of this foundational step in the new guidelines is the timeline. The timeline has shifted drastically to the left.
Meaning, we're intervening much earlier in a patient's life.
Exactly. The guidelines explicitly advocate for aggressive health behavior and lifestyle counseling to begin in childhood and adolescence.
Wow, that early.
Yes. But beyond just diet and exercise, they are pushing for pharmacological therapy to be considered much earlier in specific high-risk cohorts. For instance, in youth with genetic familial hypercholesterolemia or young adults in their 20s and 30s who have an LDL greater than or equal to 160 milligrams per deciliter, or those with a very strong family history of early heart disease.
Now, treating a seemingly healthy 25-year-old with a daily statin because their LDL is 165 feels really aggressive to a lot of people. It goes against that old reactionary model of waiting until they are 55 and their blood pressure starts creeping up.
It feels aggressive until you remember the core philosophy of these guidelines: duration of exposure. Dyslipidemia risk is not a snapshot, it is an area under the curve. Think of it like radiation exposure or calculating pack years in a smoker.
Right. I mean, smoking one pack a day for 40 years creates massive cumulative architectural damage to the lungs compared to someone who just started smoking last year.
The pathophysiology of atherosclerosis operates on the exact same principle. A person walking around with an LDL of 160 from age 20 to age 40 has accumulated 2 decades of continuous microscopic endothelial injury.
2 decades.
For 20 years, macrophages in their arterial walls have been gorging on oxidized LDL, turning into foam cells and laying down fatty streaks that will eventually calcify into hard plaque. If we wait until they are 40 or 50 to prescribe a statin, we might lower their cholesterol, but the architectural foundation of a heart attack has already been built. The structural damage is done.
By intervening at age 20, you are essentially preventing the plaque from ever taking root. You are lowering the total area under the curve for their entire lifetime.
We are shifting the medical focus from secondary rescue, trying to stabilize a plaque right before it ruptures, to primordial prevention, which is ensuring the plaque never forms in the first place.
That is so powerful. And when it comes to the bedrock of prevention lifestyle, the guidelines don't just offer vague advice like, eat better. They get highly specific, particularly regarding the management of triglycerides. For a patient with fasting triglycerides in the moderate range, between 150 and 499 milligrams per deciliter, a diet low in added sugars, low in refined carbohydrates, and low in saturated fat, while aggressively minimizing alcohol intake, is given a Class 1 recommendation.
Which highlights a crucial biological difference between how the liver handles cholesterol versus triglycerides. While a patient's LDL level is heavily influenced by saturated fat intake and deeply governed by genetics, triglycerides are exquisitely, almost instantaneously sensitive to simple carbohydrates and alcohol.
Walk us through the hepatic machinery there. Why does a plate of pasta or a few beers spike triglycerides so much faster than LDL?
When a patient consumes excess refined carbohydrates or alcohol, the body quickly absorbs the massive load of glucose and ethanol. The liver takes up this excess energy. Because the liver's glycogen storage capacity is limited, it is forced to convert the surplus carbohydrates and alcohol directly into fatty acids through a process called de novo lipogenesis.
Making new fat from scratch.
Precisely. The liver then packages these newly synthesized fatty acids into triglycerides, loads them into VLDL particles, and pumps them right out into the bloodstream. It is a direct, rapid response metabolic pipeline.
So by cutting the simple carbs and alcohol, you are literally starving the triglyceride factory of its raw materials. That makes the targeted weight loss metrics in the guidelines make a lot of sense. The guidelines specify aiming for a 5 to 10% total body weight loss, and they provide this fascinating clinical rule of thumb. Achieving that weight loss translates to lowering triglycerides by roughly 20 to 30%. More specifically, they note that you can expect triglycerides to drop by about 4 milligrams per deciliter for every 1 kilogram of body weight lost.
And that is a highly functional metric for clinical practice. It transforms a vague directive like, you need to lose weight, into a tangible, mathematically predictable goal. If a patient is highly motivated, you can tell them, look, if you lose 5 kilograms, we can expect your triglycerides to drop by 20 points. It links their physical effort directly to the objective lab results.
It's gamifying it almost.
Ah.
And the physical activity metric is equally concrete. They recommend greater than or equal to 150 minutes a week of moderate to vigorous aerobic activity, supplemented with resistance training at least 2 days a week. But here's where I want to push back a bit, or at least play the role of the frustrated patient.
Okay, let's hear it.
If I walk into any pharmacy or health food store, there are entire massive aisles dedicated to dietary supplements explicitly marketed for heart health. I'm talking about over-the-counter fish oil, red yeast rice, garlic extract, niacin supplements. If lifestyle, diet, and oral intake are so critically important to this foundational step, why do the 2026 guidelines deliver a firm, unequivocal Class 3 no benefit or harm recommendation against using dietary supplements to lower LDL or triglycerides for ASCVD risk reduction? Why is it such a hard no?
It is a phenomenal question, and it represents a massive point of friction between public perception and evidence-based medicine. The strict rejection of over-the-counter supplements comes down to the fundamental difference between lowering a surrogate biochemical marker and actually altering clinical outcomes.
Meaning, it's one thing to make a number on a lab report look slightly better. It's entirely different to prove that the pill actually stopped a heart attack.
Precisely. A specific brand of garlic extract or over-the-counter fish oil might show a marginal, inconsistent 5% reduction in triglycerides in a small, poorly controlled study. But the CCAH guidelines are not concerned with cosmetic improvements to lab reports. They are laser-focused on ASCVD event reduction, preventing strokes, preventing myocardial infarctions, and extending life.
The endpoints that actually matter to the patient.
Exactly. First, over-the-counter supplements are not tightly regulated by the FDA for efficacy or purity. The actual amount of active ingredient can vary wildly from bottle to bottle, and they are often contaminated with oxidized, rancid lipids or heavy metals.
Yikes.
Yeah. But the scientific nail in the coffin is the data. Massive, highly rigorous, randomized, placebo-controlled trials have repeatedly, conclusively failed to show that over-the-counter omega-3 supplements or standard fish oil pills reduce cardiovascular events in any statistically meaningful way.
Which stands in incredibly stark contrast to the prescription pharmaceutical versions of these lipids.
An incredibly stark contrast. For example, Prescription icosapent ethyl, which is a highly purified, chemically stabilized form of icosapentanoic acid, or EPA, has robust landmark trial data, specifically the REDUCE-IT trial. That trial demonstrated massive, significant reductions in actual cardiovascular events. The committee's nightmare scenario is a high-risk patient abandoning their proven, life-saving statin or prescription therapy in favor of unregulated, unproven supplements because of clever marketing, giving themselves a deadly false sense of security.
So for the clinician in the room, if a high-risk patient asks if they should take that giant tub of OTC fish oil they bought at a warehouse store for their heart, the clinical answer is a definitive no. It is a waste of money at best and a dangerous distraction at worst. If they meet the clinical criteria, you prescribe the pure, trial-validated pharmaceutical grade.
That is the exact takeaway. We must rely on therapies proven to save lives.
Okay, we have built a foundation. Now we need to transition into the absolute meat of the clinical algorithms. This is the core material that will dictate day-to-day prescribing, and for you medical learners listening, this is exactly what you need to master for the wards and the boards. We are moving into the specific scenarios where the prescription powder comes out. Let's start with the most aggressive, straightforward trigger in the entire document, Clinical Algorithm 1, primary prevention in the setting of severe hypercholesterolemia. If a patient comes in, they feel fine, they have no history of heart attacks, but their lab work reveals a severely elevated LDL. What is the magic threshold that changes everything?
The absolute threshold you must memorize is an LDL greater than or equal to 190 milligrams per deciliter. If you see an LDL of 190 or above, the entire standard risk assessment process is bypassed. It is an automatic, immediate trigger for initiating maximally tolerated statin therapy.
Wow, okay, no calculations.
You do not calculate a 10-year prevent risk score. You do not wait to see how diet goes. The risk is implicitly presumed to be extraordinarily high because an LDL of that magnitude is almost certainly driven by genetics, such as heterozygous familial hypercholesterolemia.
But, and this is a classic trap in clinical medicine and a favorite on standardized exams, you cannot just blindly assume it is a genetic defect and start writing the statin prescription immediately, right? There is a mandatory step you have to take first.
That is a critical point. The guidelines explicitly demand that you meticulously rule out secondary causes of severe hypercholesterolemia before committing to a lifelong genetic diagnosis. The major secondary culprits you must investigate are profound hypothyroidism, nephrotic syndrome, obstructive liver disease like primary biliary cholangitis, and a review of their current medications.
Wait, let's pause on the thyroid thing. Why would a sluggish thyroid cause an LDL of 210?
The thyroid hormone acts as a massive metabolic regulator, including the regulation of hepatic LDL receptors. The liver clears LDL from the blood by deploying receptors to its surface to grab the particles and pull them inside. Thyroid hormone is required to express and maintain those receptors.
Ah, okay.
So if a patient is severely hypothyroid, let's say their TSH is 45, their liver essentially stops displaying LDL receptors. The LDL particles have nowhere to go, so they just accumulate in the bloodstream to massive levels.
And what happens if a clinician misses that, assumes it's genetic, and prescribes a high-intensity statin to a patient with a TSH of 45?
It is a dual disaster. First, you aren't fixing the root cause of the problem. Second, profound hypothyroidism drastically reduces the clearance of statins from the body and inherently makes the muscle tissue highly vulnerable. If you throw high-dose atorvastatin at a deeply hypothyroid patient, you massively increase their risk of developing severe statin-induced myopathy or even rhabdomyolysis.
That's a perfect storm for muscle damage. And the other big one you mentioned is nephrotic syndrome. How does peeing out protein cause cholesterol to skyrocket?
In nephrotic syndrome, the damaged kidneys leak massive amounts of albumin into the urine. This drastically drops the oncotic pressure of the blood.
The blood gets too thin, essentially.
Right, and the liver senses this drop in protein and panics. It attempts to compensate by upregulating the synthesis of all proteins indiscriminately.
Yeah.
And one of the primary lipoproteins that aggressively turns out in this panic state is VLDL, which eventually metabolizes into LDL.
So the liver is just overproducing everything, trying to fix the blood density, and massive cholesterol is collateral damage. So the rule is, see an LDL over 190, check the TSH, check the urine for protein, check the liver enzymes, fix the underlying issue, and the LDL might completely normalize on its own without a single statin pill.
Exactly. Rule out the secondary noise first.
Now, assuming we have done our due diligence, it is primary severe hypercholesterolemia, and we start the patient on a high-intensity statin. This brings us to a major philosophical return in the 2026 guidelines, the return of hard biochemical targets.
This is a massive departure from previous eras. If we look back at the 2013 and 2018 guidelines, the philosophy was much more focused on the intensity of the therapy rather than hitting a specific number.
I remember that. It was all about the dose.
Right. The old advice was basically put them on a high-intensity statin, hope for a 50% drop, and whatever number you land on is acceptable. The 2026 guidelines abandon that passive approach. They bring the hard, objective, numerical targets back with a vengeance. We are in a treat-to-target paradigm.
So give us the specific numbers we are hunting for in this severe population.
It is stratified based on complications. If the patient has severe primary hypercholesterolemia, starting with an LDL over 190, but they are otherwise uncomplicated, meaning they do not have clinical ASCVD, they do not have genetically confirmed heterozygous familial hypercholesterolemia, and they do not have subclinical plaque on a scan.
The straightforward cases.
Yes. In that uncomplicated scenario, your strict goal is to push the LDL below 100 milligrams per deciliter and the non-HDL below 130.
Under 100, okay. But what if they have complications amplifying the fire?
If the fire is hotter, meaning they do have genetic HeFH, or they have proven subclinical atherosclerosis or a cluster of other major risk factors, that target drops aggressively. You must now push that LDL below 70 and the non-HDL below 100.
The reality of clinical practice is that driving a starting LDL of 240 down to below 70 is incredibly difficult. You are asking for a 70 or 80% reduction. A high-intensity statin, even at maximum dose, usually only yields about a 50% reduction. So a statin alone is going to fail to hit the target in many of these patients. This introduces the concept of the add-on cascade.
The days of writing a prescription for atorvastatin 80 milligrams, patting the patient on the back, and accepting a final LDL of 120 are over. The algorithm explicitly dictates a cascading escalation of pharmacotherapy if the target is not met.
Walk us through the steps of the cascade. What's step 1?
Step 1, assuming the patient is already tolerating a maximal statin but is not at goal, is typically the addition of ezetimibe. It is cheap, generic, oral, and well tolerated.
And if that doesn't work?
If you add ezetimibe and you are still not at the target goal, you do not stop. You proceed to step 2, which is escalating to a PCSK9 monoclonal antibody and/or adding bempedoic acid. You actively, relentlessly titrate and layer these biological mechanisms until the lipid panel submits to the numerical target.
That is a fundamental shift in the primary care mindset. You are actively engineering the lipid profile. Let's shift our focus to an entirely different biological environment. Clinical algorithm 2 deals with the diabetic patient. We have just covered isolated severe high cholesterol. But what happens when you take high cholesterol and bathe it in the chaotic metabolic environment of diabetes? This is one of the most heavily scrutinized populations in both clinical practice and high-stakes medical exams.
The scrutiny is entirely warranted. The pathophysiology of diabetes drastically alters the cardiovascular landscape. Chronic hyperglycemia induces massive oxidative stress, it glycosylates the endothelial proteins, and it creates a highly inflammatory prothrombotic state. The risk of ASCVD is so inherently elevated in a diabetic patient that the guidelines separate them entirely into their own distinct treatment algorithm.
Let's break down this diabetic algorithm by age, assuming for now that they do not already have established cardiovascular disease. Let's start with a classic, most common demographic, age 40 to 75.
For any diabetic patient aged 40 to 75, the baseline rule is incredibly straightforward. You automatically initiate a moderate intensity statin. Regardless of their specific lipid numbers, the metabolic dysfunction warrants baseline protection. Your therapeutic goal with that moderate statin is to achieve a 30 to 49% reduction in their baseline LDL, with an absolute hard target of getting the LDL under 100.
But obviously, some diabetic patients are at vastly higher risk than others. When did the guidelines instruct us to bump them up from moderate to a high-intensity statin?
You escalate from moderate to high-intensity statin therapy if the patient meets specific high-risk criteria. Specifically, if you calculate their PREVENT 10-year risk score and it is greater than or equal to 10%, or if they have multiple traditional ASCVD risk factors compounding their diabetes like severe hypertension or active smoking.
Makes sense.
If they meet those criteria, the intensity increases and the goals get stricter. You are now hunting for a 50% or greater reduction in LDL, and you must push the absolute LDL below 70.
Okay, the 40 to 75 age bracket is relatively aggressive by default. What happens when we look at the older population, patients older than 75 who have diabetes?
In the geriatric population, the guidelines embrace nuance. They advise the clinician to engage in a shared benefit-risk discussion with the patient. It is considered reasonable, which is a Class 2B recommendation, to initiate moderate-intensity statins.
But what is the limiting factor there? Why is it only a reasonable consideration and not an automatic must-do?
Because of the timeline of prevention versus the reality of aging, statins require years to drastically alter survival curves. The guidelines specify that initiating therapy is reasonable provided the patient's expected lifespan is at least 2.5 years.
Ah, I see.
If patient is 82, deeply frail, suffering from polypharmacy, and has end-stage COPD, adding a statin to prevent a heart attack 5 years from now might just subject them to muscle aches today without conferring any meaningful survival benefit. You have to weigh the abstract preventive benefit against the immediate risk of polypharmacy and quality of life.
Deprescribing and quality of life become just as important as the lipid numbers.
Now, let's swing to the exact opposite end of the age spectrum, because here is where the clinical traps are waiting. Age 20 to 39. The young adult with diabetes. The old mindset might have been, oh, they are young, they have time, just tell them to exercise. How do the 2026 guidelines handle them?
This is a crucial, high-yield caveat. You do not automatically put every 25-year-old diabetic on a lifelong statin. The intervention hinges entirely on the presence of specific markers of end organ damage. The rule is, you initiate a moderate-intensity statin into young diabetic only if specific diabetes-associated risk enhancers are present. I'm going to list these risk enhancers out, and I want you to break down the biological connection for us. Because if a clinician or a student sees these in a chart, alarm bells should be ringing. The first enhancer is a long duration of disease, defined as 10 or more years for type 2 diabetes or 20 or more years for type 1. Next is albuminuria, specifically greater than or equal to 30 micrograms of albumin per milligram of creatinine. Next is an eGFR less than 60. Then retinopathy, which is damage to the retina. Neuropathy, which is peripheral nerve damage. Or an ankle brachial index, an ABI, of less than 0.9. Why do these specific manifestations in the eye, the kidney, and the toes dictate prescribing a heart medication in a 30-year-old?
The biological connection here is one of the most elegant concepts in vascular medicine. If you look closely at that list, retinopathy, neuropathy, nephropathy, every single one of those enhancers is a microvascular complication. They represent physical damage to the tiniest, most fragile capillary beds in the body.
Right. It means the chronic hyperglycemia has been churning long enough and viciously enough to literally shred the microscopic blood vessels in the retina and the glomerulus.
Exactly. The microvasculature is essentially the canary in the coal mine for the entire circulatory system. If the tiny vessels in the eye and the kidney are taking that much catastrophic damage, it is a glaring, indisputable red flag that the macrovasculature, the massive coronary arteries supplying the heart and the carotid arteries supplying the brain, is also under severe oxidative stress and heavy inflammatory attack.
So the eye exam is essentially giving you a window into the state of the coronary arteries.
That is the beautiful synthesis of it. The presence of microvascular complications means the biological shield of the endothelium has failed. It justifies aggressive macrovascular protection with a statin, bypassing their young chronological age because their vascular age is severely advanced.
That perfectly bridges the gap between basic pathophysiology and clinical guideline decisions. We've explored the diabetic algorithm. Now let's tackle the gray area. Clinical algorithm 3 focuses on subclinical atherosclerosis. This is the realm of the coronary artery calcium, or KIC score. Let's set up the classic scenario. You have a patient in their early 50s, they feel perfectly fine, they are asymptomatic, you run their prevent equation, and they land squarely in the intermediate risk category, let's say a 10-year risk of 6 or 7%. You discuss statins. The patient is hesitant. They don't want to commit to taking a pill every day for the rest of their life based on an abstract mathematical probability. And frankly, as the clinician, you are on the fence too.
That is the classic fence-sitter dilemma. It happens in primary care clinics thousands of times a day. And this is precisely where the coronary artery calcium scan becomes the ultimate objective tiebreaker.
Explain what the CAT scan actually is physically, because we aren't injecting dye and looking at blood flow, right?
Correct. It is a rapid, non-contrast, low-radiation CT scan of the heart. What it specifically looks for is calcium. When an atherosclerotic plaque forms in an artery wall, the body attempts to stabilize and heal that inflammatory lesion by depositing calcium into it, much like bone formation.
So the calcium is essentially the tombstone of a dead, hardened plaque.
That is a highly accurate way to visualize it. The scan quantifies the exact amount of calcified plaque physically present in the coronary arteries, resulting in an Agatston score. We are no longer guessing based on risk factors. We are looking at the literal physical manifestation of the disease process.
And the 2026 guidelines provide a very specific, actionable matrix based on that Agatston score. Let's walk through the brackets. What happens if the scan comes back and the Chieki score is exactly 0?
The power of a 0 score is immense. If the patient is 0 and the patient does not have overwhelming high-risk conditions, like being an active heavy smoker or having a severe family history of premature death, it is completely reasonable and guideline-supported to defer statin therapy. You tell the patient to focus intensely on their lifestyle, and you plan to reassess with another scan in 3 to 7 years.
That's great news for the patient.
It is. A 0 score essentially de-risks the patient. It proves their arterial walls are remarkably resilient to whatever their lipid levels happen to be.
The see you in 5 years score, it is incredibly reassuring. But what if the score is not 0? What if the CC is between 1 and 99? Or perhaps the radiologist noted incidental mild coronary calcification on a CT scan that was originally ordered to screen for lung cancer.
The moment the score is 1 or higher, the paradigm shifts entirely. You now have irrefutable proof of plaque. The disease process has officially started. It is no longer theoretical. In the 1 to 99 range, the guidelines recommend initiating a moderate intensity statin. Your therapeutic goal is a 30 to 49% reduction in LDL, aiming to push the absolute LDL under 100. You are trying to halt the progression of the disease in its earliest stages.
Moving up the severity ladder. What if the CK is between 100 and 299, or if their score places them in the 75th percentile or higher for their specific age, sex, and race?
At score of 100 to 299, the plaque burden is clinically significant. You are now considering a statin as the definitive first-line therapy, and the required intensity increases. The goal shifts to a 50% or greater LDL reduction, and you are hunting for an absolute LDL below 70.
And if the CK is between 300 and 999, we are talking about extensive, widespread calcification.
The primary numerical goal remains an LDL under 70. However, because the physical plaque burden is so massive and the statistical risk of a future event is so high, the guidelines state it becomes very reasonable to intensify the pharmacological assault with non-statin add-ons, bringing in ezetimibe, a PCSK9 inhibitor, or bempedoic acid, with the explicit intent to push that LDL even lower, potentially driving it below 55.
And finally, the extreme risk category, a CAC score greater than or equal to 1,000.
A score of 1,000 or more is a profound finding. At this level of disease burden, the guidelines instruct us to effectively treat the patient as if they have already suffered a myocardial infarction, even if they have never felt a single moment of chest pain. The automatic aggressive goal is an LDL under 55 and a non-HDL under 85.
This is a truly fascinating evolution in medicine. A physical radiology scan is now directly dictating the strictness of a biochemical target. We are officially bridging the gap between structural radiology and biochemical preventative cardiology. You aren't just treating a lipid panel anymore, you are actively treating the CT scan. So we have used the CAC score to uncover disease that was hiding in silence. But what happens when the disease decides to announce itself violently? That brings us to clinical algorithm 4, secondary prevention. This is the established ASCVD patient. This is the patient who survived a myocardial infarction or suffered an ischemic stroke or has documented peripheral arterial disease requiring intervention.
In secondary prevention, the biological stakes are at their absolute highest. We are no longer guessing if their endothelium is vulnerable. They have proven beyond a shadow of a doubt that their vascular biology is highly prone to plaque rupture and devastating thrombosis.
For the very high-risk ASCVD patient, say someone who has had 2 heart attacks or a heart attack and a stroke, the guidelines have set a target that would have been completely unimaginable 20 years ago.
The target is aggressively, relentlessly low. The primary goal is to drive the LDL below 55 milligrams per deciliter, which translates to 1.4 millimoles per liter for our international audience. And the secondary goal is a non-HDL below 85.
55 is incredibly low. For decades, getting an LDL under 70 was considered the ultimate victory. Why keep pushing it down to 55?
It speaks to the new overarching mantra in modern lipidology: lower is better for longer. The shift is driven entirely by data. Massive clinical trials using PCSK9 inhibitors proved that driving LDL down to these ultra-low levels, 55, 40, even 30, is not only biologically safe, but it significantly predictably prevents recurrent cardiovascular events.
And it does more than just stop new events, right?
It does. Intravascular ultrasound studies have shown that when you push LDL down into the 50s, the physical plaque volume inside the artery actually begins to regress. You aren't just stopping the disease, you are shrinking the existing lesions.
You are pulling cholesterol out of the artery wall. The guidelines are so aggressive about this that they note even for ASCVD patients who aren't explicitly categorized as very high risk right this minute, whose immediate initial target might technically be under 70, the vast majority of those patients will eventually qualify for the under 55 goal as time goes on and they age or accrue more risk factors. The trajectory is always toward 55. But, as we discussed earlier, getting an LDL from 130 down to under 55 using only a statin is often pharmacologically impossible.
The statin just doesn't have the horsepower.
Exactly. So the clinician must tap into the non-statin arsenal. I want to pause here and review the actual molecular pharmacology of these add-on drugs. Understanding how the machinery works makes memorizing the clinical algorithm so much easier, and it is vital for clinical reasoning. The primary add-ons are ezetimibe and the PCSK9 monoclonal antibodies. Let's start with ezetimibe. How does it lower cholesterol?
Ezetimibe is an oral medication. It operates entirely in the gut. I like to conceptualize ezetimibe as a bouncer standing at the door of the small intestine. Specifically, it targets and blocks a transport protein called Niemann-Pick C1-like 1, or NPC1L1, located on the brush border of the enterocytes.
So it physically blocks the door.
Yes, it blocks the absorption of both dietary cholesterol from the food you eat and biliary cholesterol that the liver has excreted into the gut. Because this cholesterol is blocked, it gets excreted in the stool, and significantly less cholesterol is delivered back to the liver through the portal vein.
And the liver reacts to that.
Oh, dramatically. The liver senses the sudden drop in incoming cholesterol, and to compensate, it dramatically upregulates the expression of LDL receptors on its surface, pulling more LDL out of the systemic bloodstream to meet its needs.
The bouncer at the gut door forces the liver to sweep the blood. Excellent. Now, what about the heavy hitters? The PCSK9 inhibitors, like alirocumab and evolocumab. These are the injectables that can drop an LDL by another 60% on top of a statin. How do they achieve that?
To understand the inhibitor, you have to understand the normal biology. We know the liver clears LDL by placing LDL receptors on its surface. When a receptor grabs an LDL particle from the blood, it internalizes it, pulling it inside the hepatocyte. Normally, once inside, the LDL is broken down, and that valuable LDL receptor is recycled back to the cell surface to grab another particle. A single receptor can cycle dozens of times.
Highly efficient recycling program.
Very efficient. However, the liver also produces a protein called PCSK9. When PCSK9 binds to that LDL receptor on the surface, it acts as a molecular garbage tag. When the receptor gets pulled inside the cell this time, the PCSK9 tag tells the cell's lysosomes to completely destroy the receptor instead of recycling it.
So PCSK9 is essentially sabotage. It destroys the liver's ability to clear LDL.
Exactly. So pharmacology steps in. The PCSK9 inhibitors are synthetic monoclonal antibodies injected into the blood. They seek out and bind to the PCSK9 proteins, neutralizing them before they can attach to the receptors. Because the PCSK9 is blocked, the destruction of the receptors stops. The liver is forced to recycle virtually every single receptor back to the surface. It creates a massive, overwhelming vacuum of receptors that rapidly strips the circulating LDL out of the bloodstream.
The mechanism is incredibly potent. Now, the 2026 guidelines also give massive special mentions to two newer players in the pharmacological landscape. The first is bempedoic acid.
Bempedoic acid is a fascinating oral drug. It inhibits an enzyme called ATP citrate lyase. It works in the exact same biological cholesterol synthesis pathway as statins do, the mevalonate pathway, but it acts a few steps upstream of the HMG-CoA reductase enzyme that statins target.
Wait, if it works in the same pathway, why not just use a statin? What makes bempedoic acid special?
What makes it revolutionary is how it is activated. Bempedoic acid is a prodrug. When you swallow it, it is biologically inert. It only becomes an active inhibitor when it encounters a specific enzyme called very long-chain acetylcosynthetase 1, and here is the genius of the drug. That activating enzyme is highly expressed in the liver, but it is almost entirely absent in skeletal muscle tissue.
Oh, so the drug turns on and lowers cholesterol in the liver, but it remains completely inert and harmless when it floats through the muscles.
Precisely. It completely circumvents the muscle tissue. The recent CLEAR Outcomes trial highlighted its massive clinical utility. They took patients who were highly statin intolerant due to severe muscle pain, gave them bempedoic acid, and proved that it significantly lowered their ASCVD risk and event rates without triggering the myalgia.
That is the definition of a high-yield clinical pearl. If you have a patient with established ASCVD who desperately needs LDL lowering, but they swear they cannot take any statin because their legs cramp up, bempedoic acid is your new best friend. The other special mention in the non-statin arsenal is inclisiran. How does this one differ from the PCSK9 antibodies we just discussed?
While the monoclonal antibodies float in the blood and physically tackle the PCSK9 proteins after they're produced, inclisiran goes straight to the source. It is a small interfering RNA, or siRNA. It enters the hepatocytes and essentially hacks the liver's genetic machinery. It specifically binds to the messenger RNA that codes for PCSK9 and cleaves it, completely silencing the gene.
So instead of trying to catch the proteins after they are made, it shuts down the factory assembly line entirely.
Exactly, and because it alters the intracellular machinery so profoundly, its duration of action is staggering. After an initial loading phase, inclisiran only needs to be injected twice a year.
Twice a year. That's wild.
The guidelines highly recommend it for patients who either cannot tolerate or cannot obtain the PCSK9 monoclonal antibodies, or for patients who have severe compliance issues and strongly prefer the convenience of twice-a-year dosing.
It is incredible how rapidly the pharmacology is evolving. We have gone from blunt statins to manipulating RNA in the liver twice a year. Okay, we spent an enormous amount of time obsessing over LDL, which is historically appropriate. But clinical algorithm 5 takes us into territory that has long been neglected: hypertriglyceridemia. The 2026 guidelines make a massive pivot toward recognizing triglyceride-rich lipoproteins as a primary driver of residual cardiovascular risk. It is the overlooked danger in cardiology.
For a very long time, the clinical community treated triglycerides almost as a cosmetic afterthought, unless they were high enough to cause an acute pancreatic emergency. But the science has evolved. We now deeply understand that triglyceride-rich lipoproteins, or TRLs, which include VLDL and their intermediate remnants, are highly atherogenic in their own right.
Meaning they don't just hang around in the blood, they actively build plaque.
Exactly. Even though their primary cargo is triglycerides, they still carry cholesterol. And like LDL, these remnant particles can penetrate the endothelial wall, become trapped, undergo oxidation, and be consumed by macrophages to form foam cells. They drive plaque formation and intense local inflammation, just like LDL does.
So how do the new guidelines stratify the risk and treatment of triglycerides? Because you don't treat a triglyceride of 200 the same way you treat a triglyceride of 2,000.
The treatment algorithm is entirely dictated by severity. Let's start with moderate hypertriglyceridemia, defined as a fasting level between 150 and 499 milligrams per deciliter.
In this moderate range, what is the primary threat to the patient?
In the moderate range, the primary threat remains chronic ASCVD, the slow buildup of plaque over years. Your clinical focus is on calculating their PREVENT 10-year risk score, and the foundational treatment algorithm says you maximize their statin therapy first.
Wait, I thought statins were for LDL. Do statins lower triglycerides too?
They do, significantly. By upregulating LDL receptors on the liver, statins also increase the clearance of VLDL remnants. A high-intensity statin can reliably lower triglycerides by 20 to 40% while simultaneously crushing the LDL risk.
Okay, so moderate triglycerides are handled with a chronic vascular disease mindset. Statin first. What happens when the level crosses the threshold into severe, meaning greater than or equal to 500 milligrams per deciliter?
At 500 and above, the immediate clinical threat fundamentally shifts. You are no longer primarily worried about a hypothetical heart attack 10 years from now.
Yeah.
You are actively, acutely worried about acute pancreatitis happening tomorrow.
Why does fat in the blood cause the pancreas to destroy itself?
When triglycerides cross into the severe range, the blood becomes heavily laden with massive, bulky chylomicrons. These particles are physically enormous. As they try to navigate the tiny, delicate capillary beds of the pancreas, they physically jam up and occlude the microcirculation, causing local ischemia.
A physical traffic jam.
Yes. Furthermore, the pancreatic lipases begin breaking down these massive fat particles right there in the capillary bed, releasing a flood of highly toxic free fatty acids that cause direct caustic chemical burns to the pancreatic axonar cells, triggering massive necrosis and inflammation.
A chemical burn triggered by a physical traffic jam of fat. That is a terrifying visual. So at 500, you must optimize their diet, cut all alcohol, and immediately manage the threat of pancreatitis. But then there is the extreme category, levels greater than or equal to 1,000, which often points to a genetic disorder like familial chylomicronemia syndrome, or FCS.
At levels over 1,000, the blood physically changes viscosity. It literally becomes milky and opaque. The risk of sudden life-threatening hemorrhagic pancreatitis is extremely high. The core mandatory intervention here is not just a diet. It is a highly restrictive, incredibly challenging, very low-fat diet. We are talking about restricting dietary fat to 10 to 15% of their total daily calories, maximum.
That is incredibly hard for any human being to maintain in the modern food environment. So what pharmacology do we use to help them survive at these extreme levels?
The classic pharmacological tools are the fibrates, specifically targeting the use of fenofibrate.
Why fenofibrate specifically? Why not gemfibrozil, which is also very common?
This is a critical safety point. You must avoid gemfibrozil if the patient is on any kind of statin. Gemfibrozil drastically interferes with the glucuronidation pathway in the liver, which is the exact same pathway statins use to be cleared from the body. If you give gemfibrozil and a statin together, the statin levels spike to toxic concentrations, drastically increasing the risk of catastrophic muscle breakdown or rhabdomyolysis. Fenofibrate uses a different metabolic pathway and is much safer to combine with the statin. You can also deploy high-dose prescription omega-3 fatty acids.
And the 2026 guidelines introduce an entirely new class of drug for this extreme genetic category, olezarsen.
Yes, olezarsen represents a breakthrough. It receives a Class 1 recommendation for adults specifically diagnosed with FCS who have fasting triglycerides persistently over 1,000. It is an APhA-C3 inhibitor.
Oh, APhA-C3. Let's dive into the biochemistry. What does APhA-C3 do normally, and why are we inhibiting it?
Apolipoprotein C3 is a protein that normally acts as a brake. Its primary job is to inhibit an enzyme called lipoprotein lipase, which sits on the walls of blood vessels and breaks down triglycerides to clear them from the blood. In patients with FCS, their triglyceride clearance is already severely broken. By using olezarsen to inhibit APhA-C3, you are essentially removing the brakes.
Oh, wow.
It unleashes whatever residual lipoprotein lipase activity the patient has, allowing it to rapidly, aggressively clear those massive chylomicrons out of the circulation, drastically plunging their risk of a fatal pancreatic attack.
Removing the brakes on the triglyceride-clearing enzyme. That is an awesome, elegant mechanism. Now, I want to pull us back from the extremes of pancreatitis and return to the chronic cardiovascular risk of moderate triglycerides, because there's a specific drug scenario here that causes endless confusion, and the guidelines clarify it beautifully. We need to talk about the role of icosapent ethyl, or IPE.
This is arguably one of the most critical practice-changing recommendations in the triglyceride section. Let's outline the scenario. You have a patient who already has established clinical ASCVD, or they are at very high risk, perhaps diabetic. You have them on a maximally tolerated statin. The LDL is controlled. But their fasting triglycerides remain stubbornly elevated in that moderate range, say between 150 and 499. In this specific scenario, the guidelines state that icosapent ethyl is uniquely recommended as an add-on therapy.
Here's the question every student will ask. Why uniquely IPE? If the goal is just to lower the triglycerides, why not just add a cheap fibrate or a niacin pill?
Because the ultimate goal in cardiology is not to make the numbers on the lab report look pretty, the goal is to keep the patient alive. Icosapent ethyl is the only triglyceride-lowering drug that has actually proven it reduces hard ASCVD events in this exact clinical scenario, based on the landmark REDUCE-IT trial.
The trial data is the dividing line.
Completely. We have decades of massive clinical trials testing fibrates and niacin. Yes, fibrates and niacin will successfully lower the triglyceride number on the lab report. But when they are added on top of background statin therapy, trial after trial has failed to show that they prevent heart attacks, strokes, or cardiovascular death. They fix the number, but they don't fix the patient. Icosapent ethyl, which is highly purified EPA, has pleiotropic effects. It stabilizes cell membranes, it reduces local inflammation in the plaque, and it actually saves lives.
That is the ultimate bottom line for the wards and the boards. Do not add a fibrate to a statin just to cosmetically lower a moderate triglyceride number if your actual goal is cardiovascular risk reduction. Use icosapent ethyl. All right, let's bring it home with Section 8, Special Populations. To round out our mastery of these guidelines, we have to look at the edge cases. These are the complex scenarios that examiners love to test and that real-life clinics struggle with daily. First, let's look at the intersection of cardiology and obstetrics. The guidelines place a massive new emphasis on reproductive risk markers.
This is a fantastic, long overdue update. The guidelines now formally recognize that pregnancy acts as a profound 9-month biological vascular stress test. It pushes the maternal endothelium to its absolute limits. Conditions that occur during pregnancy, specifically preeclampsia, gestational diabetes, and preterm delivery before 37 weeks, are now officially codified as risk-enhancing factors.
So the stress test unmasks a hidden vulnerability. If a 45-year-old woman is sitting in your clinic and her prevent risk score is borderline, you absolutely must ask about her obstetric history. If she tells you she had severe preeclampsia 20 years ago during her first pregnancy, how does that change your management?
It changes everything. Preeclampsia means her vascular endothelium failed the stress test. It indicates a deep-seated predisposition to endothelial dysfunction and heightened inflammatory response. Her vascular system has already shown you its vulnerability. That history alone tips the scale heavily toward initiating a statin earlier because you know her biological resilience is fundamentally compromised.
We cannot ignore the vascular history written during pregnancy. But what about managing a patient's dyslipidemia while they're actively pregnant or lactating? So if a pregnant patient has severe, dangerous hypercholesterolemia, what are the safe pharmacological options?
If intervention is absolutely necessary, the guidelines state it is reasonable to use bile acid sequestrants, like cholecalciferol. These drugs act entirely within the lumen of the gut to bind bile acids. They are large polymers that are not absorbed systemically into the maternal bloodstream, meaning they cannot cross the placenta and harm the fetus.
A clever physiological workaround. But what if the pregnant patient is facing a different threat? What if she has severe hypertriglyceridemia, say levels soaring over 500 or 1,000, and she is at imminent risk of developing acute pancreatitis, which could be fatal for both her and the baby?
That is an obstetric emergency. In that scenario, the risk of pancreatitis outweighs the pharmacological risks. The guidelines advise that after the critical organogenesis of the first trimester is complete, the careful use of fibrates, or high-dose prescription omega-3 fatty acids, is considered reasonable to drive those triglycerides down and prevent a pancreatic crisis. And in most extreme genetic cases, like a pregnant patient with homozygous familial hypercholesterolemia, whose LDL is unimaginably high, lipoprotein apheresis, which is essentially physical dialysis to filter cholesterol out of the blood, is a safe and highly effective mechanical option during pregnancy.
Those are wondrously clear, mechanism-based rules for navigating pregnancy. Now, let's tackle the issue that is the absolute bane of every primary care doctor's existence, and the reason so many patients abandon their therapy. Statin-attributed muscle symptoms.
It is an incredibly common, intensely frustrating clinical hurdle. A patient starts a statin, and a few weeks later they complain of bilateral thigh aching, weakness, or cramping. The guidelines advise a very systematic approach. First, you must take it seriously and attempt to confirm if it is truly the statin, while simultaneously ruling out secondary causes that might be causing the myalgia, such as unrecognized hypothyroidism or a severe vitamin D deficiency.
Assuming it is the statin, what is the protocol? Do we just give up?
Never give up on the first try. The protocol is to wash the patient out, let the symptoms resolve, and then attempt to re-challenge them. You might try a much lower dose, or you might switch the pharmacokinetic profile entirely. For instance, switching from a lipophilic statin, like atorvastatin, which penetrates muscle tissue easily, to a hydrophilic statin like mosuvastatin, which stays more confined to the liver.
But the clinical reality is that some patients truly cannot tolerate any statin at any dose. Their muscle biochemistry just rejects the mevalonate pathway inhibition. If they're statin intolerant, but they have a massive ASCVD risk, what is the next move?
This is exactly where the new pharmacology shines. As we discussed in depth earlier, bempedoic acid is a massive Class 1 recommendation here. Because it requires a liver-specific enzyme to become active, it remains completely inert in the muscle tissue. It circumvents the mechanism of myalgia entirely while successfully lowering ASCVD risk. PCSK9 monoclonal antibodies are also heavily recommended in this scenario, as they work on external receptors and do not interfere with intracellular muscle metabolism.
And finally, to wrap up our clinical mastery, when does a general practitioner or internist need to throw in the towel, admit the case is too complex, and refer the patient to a clinical lipid specialist?
The guidelines outline clear triggers for when you need to call in the cavalry. You must refer if the patient has suspected homozygous familial hypercholesterolemia, as their risk of childhood myocardial infarction is profound. You refer if their fasting triglycerides persistently remain over 400 milligrams per deciliter despite your optimal management with diet and statins. You refer if the clinical picture is muddy and they require specialized genetic testing for complex inherited lipid disorders. And you absolutely refer if the patient's disease is so refractory that they are potential candidates for advanced, specialized therapies like lipoprotein apheresis or rare disease orphan drugs like evinacumab, lamidipide, or the new APhA inhibitor olezarsen we just explored.
The cavalry is there for a reason, and knowing when to ask for help is a sign of a great clinician. Okay, let's take a breath and recap our core mission for this deep dive. We set out to understand how the 2026 guidelines rewrote the rules of preventive cardiology, and we've covered massive ground. We completely upgraded our foundational math, tossing out the flawed fixed-ratio Friedewald formula and the old PCE in favor of the dynamic Martin-Hopkins equation and the holistic kidney-aware prevent score. We explored how LPA and APhA expose hidden, genetic, and particle-driven risks. We recognized a profound philosophical shift. Early lifestyle interventions and early pharmacotherapy act like a biological time machine against plaque formation, because the ultimate enemy is the absolute duration of exposure over a lifetime. We mastered the aggressive new algorithms, learning the exact cascade from high-intensity statins to ezetimibe to PCSK9 inhibitors to hit relentlessly aggressive targets, like driving LDL under 55 for our most vulnerable high-risk ASCVD patients. We navigated the dangerous waters of triglycerides, pivoting our clinical mindset from chronic ASCVD risk at moderate levels to acute catastrophic pancreatitis risk at the 500 mark, and detailed the trial-proven superiority of icosapent ethyl over fibrates. And we charted a safe course through the complexities of pregnancy and statin intolerance.
It is a phenomenal, deeply comprehensive framework. It truly modernizes how we perceive, quantify, and ultimately dismantle the physiological drivers of cardiovascular disease.
But before we let you go, we want to leave you with a final thought to mull over, building on the biology we just discussed.
The entire premise of the 2026 guidelines rests heavily on this concept of the duration of exposure to atherogenic lipoproteins. If dyslipidemia truly acts like continuous radiation exposure, or the cumulative pack years of a smoker, where the lifetime accumulation of microscopic damage is what dictates the final fatal event, it forces us to look to the future. Will future iterations of these guidelines eventually recommend screening for genetic cholesterol and LPA markers in early childhood and treating them not with daily pills, but with once-a-year or even once-in-a-lifetime CRISPR gene silencing therapies? Could we effectively vaccinate humanity against atherosclerosis before a single microscopic foam cell can form in an adolescent artery? It fundamentally challenges how we think about the inevitability of aging and the very nature of heart disease.
We started this hour comparing cardiology to an X-ray of a broken arm. We have evolved from waiting for the bone to snap to actively developing a vaccine against a slow-burning fire. Thank you for joining us on this deep dive. Take these physiological concepts, apply these modernized algorithms in your clinics, avoid the traps on your exams, and we will see you next time.